All right. Hi, everyone. Welcome, welcome. I hope you all are doing well. Thank you so much for joining. We're going to take a few minutes here as we're waiting for everyone to trickle on in. But in the chat box, if you can, if you could put in your name, if you can put in your pronouns, if you could also put in where you're from, if you are a provider or if you are a community member, you can also put that down in the chat. So let's see. I'm going to type everything that I just said so you'll be able to participate. All right, so I just put it in the chat. So if you can, you're going to put in your name, your pronouns, where you are, if you are a provider or if you are a community member, and you're going to put that in the chat. If you're a participant, panelists, you can feel free to do it too if you want to. But I really would like to see some engagement in the chat if we can. And in the meantime, I'm actually going to go ahead and share my screen. We're going to get started in a few minutes. I just want to give people the ability to come on in. They might be coming from other organizations or other Zooms. So I just want to give people a few minutes. We're going to go ahead and get started at 2:05. So I'll give people about 2 minutes to settle in. Just a reminder, we're going to get started in 1 more minute. If you haven't already, you can put your name, you can put your pronouns and where you're from, whether you're a provider or a community member, and go ahead and put that in our chat if you please. All right, so on my end, we have 2:05, so we're going to go ahead and get started. Welcome, everyone. I am so happy to have you here. This is the Your Decisions Matter During COVID-19 webinar. Today is Thursday, August 13th, and this has been brought to you by Garden State Equality, Atlantic Health System, and Sage Elder Care. And so I want to go ahead and get started here. And so Garden State Equality is a statewide LGBTQ organization that does advocacy as well as programmatic efforts for the entirety of the community. We have three major initiatives. Our first one is Map and Expand, which works with LGBTQ competency training for healthcare providers. We have Teach and Affirm, which works with our youth, so providing administrators, educators, faculty, and staff information to support LGBTQ students. And then our initiative Pledge and Protect, which is our LGBTQ older adult initiative. And so I put our website here, and we're also on Facebook, Twitter, and Instagram. I urge you all to check our organization out. If you're interested in any of these programs, definitely feel free to email me and I'd be more than happy to accommodate you. And so I want to talk a little bit more specifically about the Pledge and Protect initiative, which is the older adults initiative, simply because for the most part, when it comes to different subject matter, this is the one in terms of where today's program falls underneath. But I would be remiss to say that, making a decision like this and having these hard conversations is appropriate and applicable for all ages. It's not just an older adults issue. It does exist throughout the lifespan of an LGBTQ person or a community member in general. And so I'm going to introduce myself. My name is Bianca Mays. I am the Health and Wellness Coordinator of Garden State Equality. My pronouns are she, her, hers, and I'll be a moderator for today's conversation. Just some housekeeping. This is a webinar, not a meeting. And so if you are a participant, you will not have access to putting on your video camera. You might not have access to turning on your microphone, but you can engage by participating in the chat. If you have any questions, since today is mostly going to be an informal conversation about how we can address these issues together, you can either put your questions in the chat or you can put your questions in the Q&A, and I'll be able to answer it and ask the panelists when the time is appropriate. And so I'm going to move forward here. This is basically the agenda for today. I'm going to open a little bit with LGBTQ aging issues. And we're going to have Nina talk to us a little bit about Your Decisions Matter. And then we're going to have our panel. And our panel consists of different organizations, and I will introduce them all to you in short time. And then we're going to have a Q&A. So I think it's really important that we engage each other as we're having this conversation, simply because this can be applicable to anyone's workspace, really. And so this issue of, being able to talk about creating a plan, right? A plan for you as you hopefully be able to age, a plan as you examine your healthcare outcomes, came to me through a needs assessment that I conducted throughout the state of New Jersey. I basically went around surveying different people, asking, what specifically do you need to age here? What kind of services are you looking for? Are you interested in taking this step towards, providing your loved ones with a concrete plan as to what they need to do to take care of you? And so when I embarked on this journey, I not only did I hear about the need for presentations like today, but also hearing about the need for social connection. I'm sure you all have experienced this, especially during COVID. There is a need for social connection. People need to have more conversations. People are worried specifically about their LGBTQ status when it comes to, hiding who they are or their healthcare decisions. Something that comes to mind, at least for me, is, if people aren't close with their biological families, how are they participating in this conversation, right? Thinking about the need for quality services. I know a lot of people that I have spoke to through my research. One of the reasons why they actually delayed this service is because they might not have considered themselves in a place where they could ever make this decision. I know a lot of them are so used to being discriminated against and are scared when it comes to seeking any kind of service. So really working on that as a community and as providers is going to be key here. And then, thinking about, where people want to live. Do they want to stay at home? Will they be placed in a facility if they're unable to take care of themselves? What are the living arrangements here specifically for LGBTQ elders or older adults, simply because New Jersey doesn't have specific LGBTQ living arrangements other than the one homeless shelter that we have, which is catered towards youth. So if you're over 18, unfortunately, we don't have anything for you right now. So we're trying to work on these housing issues together as a state to make sure that we're as accommodating as we possibly can be for everyone. And so it also includes the advocacy piece, and this is going to be huge here. Many members of the community are very hesitant when it comes to taking this step. Some of them are a little bit behind. And when it comes to, advocacy efforts in general, most of LGBTQ advocacy is very focused on certain healthcare disparities, including HIV, mental health, taking care of our youth, which is super important. However, we know that there aren't enough LGBTQ people that are advocating in terms of making their own decisions, sitting down and coming up with a plan for themselves. And so we're going to examine that today and see how are we going to be able to push this forward for all members of our community. And so now I'm going to ask Nina, who Nina Tiger is associated with Your Decisions Matter. I'm actually going to read your bio here, if you don't mind, Nina. So Nina is the project coordinator of Your Decisions Matter, which is a community-based initiative from Sage Elder Care and Summit, which launched in September of last year. So the goal of Your Decisions Matter is to encourage family members to have conversations with their loved ones and healthcare providers about end-of-life care and decision-making, ideally before a medical crisis, right? We are now in COVID-19. We have to start having these conversations with our loved ones. It's so important, especially since we don't know how long it's going to be until we have a vaccine, until we're able to return to our, our normal activities. The program is funded by Chilton and Overlook Medical Center community advisory boards. And when people attend the Your Decisions Matter event, you receive a starter kit with tips and tools on how to begin these difficult conversations. I've been given that toolkit, and I can give it to everyone that has RSVP'd, because we want you to have this information. We definitely want you to have this information here. Before COVID-19, Your Decisions Matter offered in-person events like workshops and movie screenings, fun settings where we can talk about difficult conversations. But now the programming is virtual through Zoom webinars like today, and meetings can be found on their Facebook page. And so I'm going to let Nina take it away. I'm so excited to have you here. Thank you, Nina.
Okay. Hi. Thank you so much, Bianca, for doing this webinar with Your Decisions Matter. We're really excited to be part of it. Like you said, our program's goal is to encourage people to talk to their loved ones about end-of-life care and decision-making, ideally before there's a medical crisis. And we're funded by Atlantic Health, Overlook, and Chilton Medical Center's community advisory boards. I work at Sage Elder Care, which was established in 1954 as a nonprofit that services the need of older adults, families, and caregivers. And this program, as you said, launched in September of 2019, and we were doing in-person workshops and movie screenings and different events. And now we've pivoted to online because of COVID. So thank you so much for having us today. We think it's important for people to have these conversations, like I said before, there's a medical crisis. And when you have the conversation, you're really giving another person an understanding of what matters most to you at the end of your life. And it will make decisions easier for you and that person who has to make decisions for you. Over 90% of people think it's important to have these conversations, but only 32% of people have actually had them. So one of the main goals of our program is to encourage people to do that. Here are objectives on this slide. As I said, we're encouraging family members and loved ones to talk about end-of-life care and decision-making. We're providing tools on how to start a conversation. As Bianca said, we have a starter kit from the Conversation Project that gives tips and tools on how to start the conversation, who you might want to talk to, what you want to be sure to say. And it really goes through not only what matters to you spiritually, but also medical concerns that you might have when you cannot speak for yourself and you want that person who's your advocate to know your wishes. We also want to normalize the topic. This is something that is uncomfortable for a lot of people to talk about. There's some cultural differences in different cultures. People feel it's bad luck to talk about it. They only have elders in the community talk about it. They have a distrust of doctors. We're trying to help people break down those taboos. And also just in general, I think people are scared to talk about it. They don't want to upset their loved one, or they just don't know how to start this conversation. And if you go to our Facebook page or our website, or download the starter kit, we give some really good icebreakers on how to do that. And then we also try to follow up with participants who come to our workshops and see if they need some extra help. One of our main goals is that we want everyone to know that this is just one conversation. This is something that you want to talk about over time, and you can change your mind and change what you think about what you want medically at the end of your life. So it's sort of normalizing it so families are communicating better. And if you do talk to someone about end of life, your wishes, it's really helps that person because they feel like they are being heard. And it also helps you if you are their decision maker when the time comes where you have to make these difficult decisions, you know what their wishes were. Another situation that we hear about quite often is different family members who aren't in the loop when the person is in a medical situation and they can't speak for themselves. Then that person who is speaking for them and is their decision maker is not in agreement with what everyone else wants. So a big this is communicating with everyone in your family or your friends and letting them know what your wishes are. So at the end, you are all in agreement and there isn't discourse, which happens quite often in the hospital setting. We also think that during COVID-19, our message has pivoted a little bit because we know that people are very anxious now and afraid. And so we've sort of broken it down into 3 things you can do now to be prepared. One, the most important one is to pick that person to be your healthcare decision maker. It doesn't need to be a family member. It can be a friend. It can be a clergy member. It can be someone at the hospital, a social worker, your primary care physician. But it's important to have someone who has that information and is ready to speak for you. And then to think about what matters to you most at the end of your life or if you are in a medical crisis. And then also think about what you would want if you become seriously ill with COVID-19 specifically or with other illnesses as well. And people have mentioned to me when I've been doing these workshops that the way we're communicating now over Zoom and over the phone, it actually is a little bit easier sometimes to have conversations about this serious subject that way, as opposed to face to face. There's something about the disconnect of being over the computer, over the phone, which makes it a little bit easier to talk about serious subjects. So I think that was a good point that someone told me worked for them very well. And also using what's going on now in the world sort of as the icebreaker. You could say to someone, I saw something on the news or I heard about our neighbor. What if that happened to you, what would you want to do? How could I help you through that situation? So that's just sort of a brief overview of what Your Decisions Matter is hoping to do in the community, helping people communicate better and share what is important to them at the end of their life with a loved one or a friend. Oh yeah, these are some statistics that we have. So as I said, over 90% of people think it's important to talk about end of life decision making, but 32% have actually done so. So that's a big disconnect there. And then I think there's another slide. Bianca, do you want to go to the next slide? 21% have not had the conversation because they don't want to upset a loved one. But in fact, I can do it. Can you go to the next one, Bianca? All right, 53% said they would be relieved if a loved one started the conversation. And then 95% of people are willing and want to talk about their end of life wishes. So I think all those statistics really show that people do really want to talk about this with someone and get prepared in case something happens.
Thank you, Nina. And now we're going to move more into our panel piece. So we're joined here by Dr. Ray Centeno, a Ph.D., a licensed professional counselor in New Jersey. He received his Ph.D. in counseling psychology from Seton Hall and currently holds the post as the coordinator of outpatient behavioral health services at Morristown Medical Center. Ray has worked with the LGBTQ community as a treatment provider and an educator for over 20 years. He has provided lectures focusing on LGBTQ issues amongst the youth and older LGBTQ adults. Throughout his career, he has worked to promote HIV/AIDS awareness through his advocacies and research, especially focusing on Asian/Pacific Islander communities, which we all know could definitely use a lot more research and education. Ray also has a private practice in the Jersey Shore area. We're also joined by Bill Singer. Bill Singer is a managing partner at the Singer and Fedun LLC in Somerset County, New Jersey, where he's practiced for 47 years. Bill is also counsel to the law firm of Diana Adams Law and Mediation, PLLC, in New York City. His practice concentrates on the creation and protection of families for all configurations and a counselor to nonprofit organizations. You already heard the bio of Nina, so I'm going to move on to Victoria. So Victoria Veninata is a social worker for the Atlantic Health System's Geriatric Assessment Center in Morristown, New Jersey. The Geriatric Assessment Center specializes in providing primary care and consultative geriatric assessments to patients ages 65 and older. This interdisciplinary team evaluates and treats age-related health concerns. And as a social worker, Victoria provides psychosocial assessments and support to geriatric patients and their loved ones. And Victoria also connects the patients and their support systems to determine appropriate community resources and caregiving services. So I'm so happy to have everyone here as a panel. I'm going to stop sharing my screen so you'll be able to see all of our wonderful panelists here. And we're gonna move into the conversation here, which I'm really excited about. So let me unmute all of you so you can be able to participate here. So something that I want to do a little bit more digging into is the unique challenges that members of the LGBTQ community probably are feeling right now in response to what's going on. I know when I was doing this and going in the field, something that came up quite often is, something that stuck out to me. Someone said, I didn't think to start planning because I never thought I would make it this far in my life. I thought that, during the HIV/AIDS epidemic, seeing all my loved ones and my friends pass away, I didn't think I would get here. And so a lot of it is, survivor's guilt that some people have indicated that they've felt as a reason why they haven't gotten here yet. Ray, I don't know if you want to speak about this, but what do you think what is it like to grow older as an LGBTQ person?
Ray, you have to unmute.
Uh-oh, we have some technical difficulties. Ray, if you can hear me, I'm asking you to unmute yourself.
Can you hear me?
Yep.
Yeah. Yes.
Wonderful. Oh, wonderful. See, I'm good at talking, but I'm not that good with technology. So first of all, I'd really like to take this opportunity, Nina, Bianca, to thank you for really setting this endeavor up, and I feel it's vital, and what I'm also very thankful for is that we are in the times that we're in allows us to actually be able to talk about things like this within the context of LGBT issues. I don't think that we would be having this conversation 30 or 40 years ago. I think if we did, we would be whispering about it. The first thing that I'd really, on my end, would like to have a conversation with everyone has to do with, first of all, really looking at the landscape in which older LGBT adults currently are faced with. And I think before we can talk about the present, I think we need to talk about I would say the watershed moment that was vital in terms of allowing us to have these conversations. And I'm talking about the case of Windsor versus the United States. It was in 2011, June 26th. And I still remember around 10 a.m. watching TV when I was Channel 7 that I was watching, and the news reporter was showing how these, when the Supreme Court basically handed down its judgment regarding the Defense of Marriage Act, and how historic it was for them to say DOMA is dead. And we have to thank Edie Windsor, God bless her soul, for being the person who really fought. Whether she knew it or not, she was the key person that allowed LGBT individuals to, for the most part, partake in the same rights and privileges that other Americans have. And I think that we have to recognize that as a watershed moment. For older LGBT adults, though, prior to that, the experience has been different. And despite the different freedoms and the rights and that a lot of LGBT individuals experience now, especially the younger ones. And I always make it a point to tell the story of Edie Windsor to the younger folks, is that it was a whole different landscape. It was a landscape where the narrative has always, for the most part, has been to not acknowledge who you are. To people that you know, to coworkers, and for the most part, to not acknowledge who you are to your family members. And that has been the challenge in terms of, as someone working in the mental health field, that does a lot to someone's ability to look at themselves as someone that's worthy. It does a lot in terms of one's self-worth. It does a lot in terms of one's ability to partake in the different traditions that human beings and families typically have. And so, with regards to, receiving health care, that has been a significant challenge for a lot of LGBT individuals. And for older adults, that becomes particularly even a bigger issue, because even up to now, the narrative and the lives that they've lived still affect how they're able to make really important life decisions, end-of-life decisions, and how we as healthcare providers address them. One of the stories that I want to share, and I remember is, I used to work with a nurse in an emergency room setting, and we were talking about, how we treat patients, how we treat people. And her response to this, and I know that it was well-intentioned, she goes, "I don't care who you are, you get the same treatment from me. I don't care if you're black, brown, yellow, purple, gay, straight, I treat you the same way as I treat any other individual." And I know it was a well-intentioned statement, albeit, if we really look at it, it was a misinformed statement, because it matters. It matters to know who you're dealing with and who you're providing services for. And that's a particularly very important issue when you're dealing with someone who is who identifies or who is part of the LGBT community, because it's what their experiences are and their life narratives matter in terms of how we can be able to address issues with them, and in the manner in which we do, because of the unique history that they've experienced. We know that they've experienced discrimination for the most part, whether it's overt or covert, and that affects in terms of their ability, even until now, to even whether they self-identify as gay, straight, bi, and you know, it's really important. The onus comes in terms of healthcare professionals. The onus is on us to be able to assist and facilitate them being able to be very honest with us so that we can provide the most appropriate level of service for them. That's particularly very important for the trans community, transgendered community, because they've, even until now, continued to experience significant discrimination.
And I
would say more than Bianca, you want to say something?
Yeah, you said something that really stuck out to me that I think a lot of people don't know. I think that when people think LGBTQ, I think they think that all LGBTQ people have similar issues. And I do want to reinforce that if you are trans, the health disparities that exist for you are actually double cisgender, lesbian, gay, and bisexual people. So the LGB, if their sex assigned at birth aligns with their gender identity, they're still going to be better off in the healthcare industry and better off in the world than when it comes to lived experiences and discrimination than someone who is transgender, someone whose sex assigned at birth differs from their gender identity. And I think that distinction definitely should be communicated more effectively when it comes to the LGBTQ community, because we're not all, a monolith, and people do have different experiences, which can contribute to poor healthcare outcomes, especially trans people. And, that is something to take into consideration, especially when it comes to Nina. Something that you said that really stuck out to me was that you don't need to be a family member to be able to, make these decisions or, start these conversations. And I would love to hear you speak a little bit more about that, simply because I think very often we have a very biological family model in this country where, if you are a trans person or if you are a part of the LGBTQ community, where you are less likely to have the support of your biological family, would you be able to speak more on that, Nina, about how you can have other people have this decision-making process with you? Uh-oh, I think you muted.
She's muted.
There we go.
I was trying to do it myself and it said I couldn't do it. Yes, well, I've heard that from a lot of people that I did a workshop at a synagogue last November, and a woman was there and she was listening to what all the different choices I was throwing out for who would be someone to have the conversation with. And she said, I don't have any family. I have a brother who's alive, but we're estranged. There's no one who I would even feel comfortable having this conversation with, let alone have that person be my designated proxy. And then the rabbi who was running the workshop with me said, I will do it for you. Come meet with me. Anytime, we'll work it out together. We'll fill out the forms. I'm happy to be your designated speaker. So I think that was just a really powerful moment for everyone in the room, because the woman was so down and just depressed about the whole situation that she really didn't have anyone. And for the rabbi to step up and do that was amazing. So, I mean, I think there are people out there that you can turn to if you don't feel comfortable asking a good friend you can ask other people, and there are people in the hospital. I'm sure, Victoria, you can speak to this. I know that people in the hospital, social workers, hospitalists are happy as well to meet with people and help them fill out paperwork and find out what matters to them and help them with the situation as well.
Yes, definitely. So I work in an outpatient setting. I'm in a regular primary care doctor's office. That's my 5-day-a-week job. And what I really find value in is here at the practice, the goals is for them, of course, to establish care here with a primary care doctor. And with that, we're not only getting insights into what is your medical record, what is, you have diabetes, you have high blood pressure. It's also, and this is one of the main reasons why I, as the social worker here, I do a new patient evaluation and assessment with all of our patients. That's a blanket. When they come into our office, they get the doctor, but they also get me. So it's an opportunity for me to gather information as to who they identify as part of their support system, and get that good understanding up front. I'm communicating that with the doctors. And then I always talk about the long-term planning documents every new patient assessment that I have, asking if the person has one. If they don't have one, maybe what are some of the hangups or why they're uncomfortable? Have they thought about it in the past? And a lot of my big role here is talking about some misconceptions that people may have about the advance directives as well, because it's so often perceived as this document that's like the death document, and we don't talk about it until we're older and we have complicated health issues, and this is when we start discussing this document. And I think that is a valuable opportunity for us to break that stigma or that pre-existing idea or notion about this and say, no, you identified to me that, you have this very close friend that you've known for 50 years, or you're very close with your neighbor, and or maybe somebody in the family, and how can we bring this into your like understanding, how can I have the conversation with you, but also at a later point, if they want to have the conversation, have me call up, or I know now in light of COVID, we're doing a lot more Zooms, which is wonderful as well. So how can we have these conversations, whether it be in the office, over the phone, or virtually, and break down some of the ideas about what the advance directive is and get their chosen support system involved in the conversations.
Thank you. I think one of my questions is, and maybe Bill, you might be able to answer this, if someone's loved one does decide to embark on this journey, what documents do they need to have to be able to help them protect themselves? Because it's one thing to be a family member, which in certain cases you have more rights unless you have the paperwork indicating that, no, this person can help me make this decision to protect myself. What does a person need to know / have? Because I know that there's probably many documents that need to be put in place before this even happens.
Thank you, Bianca. I just want to point out also that although the Windsor case that Ray talked about was very important, I find more significant going back to Stonewall, because people who grew up before Stonewall approach these issues much more differently than younger people. Younger people grew up in a time when gay and lesbian, bisexual people were more accepted, now trans people. But those of us, I'm a pre-Stonewall generation person. I grew up at a time when it was pathologized, when it was criminalized to be gay, when you would get thrown out of your job, you would be estranged from your family. So many people of that generation are not as keen to talk about these things because of the way they grew up. And you have to sort of wean them a bit. I have people who come in and they present as roommates. They've been roommates for 50 years. Well, that's not the case, but that's just how they got socialized. So if you're talking to people pre-Stonewall, it may take more to get them to recognize or to feel comfortable to them to give you an explanation of what the real relationship is. So I always tell people there are 4 documents you need to consider. A will, of course, and we're not going to talk about a will today because that's not really within the medical framework. But you need a will. But many people have, the major assets they have are a life insurance policy or a retirement plan, an IRA or a 401k. Those are controlled by beneficiary designations. So just having a will is not enough. If you write in your will, I leave my life insurance to X, but you wrote on the beneficiary designation Y is getting it. So those have to be coordinated. Another document that's, I think, really key is a durable business power of attorney. If you become disabled, who can make this business decision for you, have access to your money, deal with your automobile, deal with your credit cards, sell real estate. A lot of people, people in same-sex relationships now feel, well, I'm married, so I don't need anything like that. My spouse can sign for me. That's not true. Your spouse cannot sign your income tax return. Your spouse cannot sign the deed when you decide you need to sell the property. A business power of attorney is a relatively cheap document to get. If you don't have it, you have to end up going to court, being appointed conservator of an incapacitated person, get doctor's notes. You're in a time of emergency and need. It's going to be like 6 weeks before you get authority to act, versus if you have this relatively inexpensive document, you may never need it, but if you have it, you don't need any of that. You just cut through. All right. So now I just want to address the two medical documents. So a lot of people think a living will is what you need. And a living will is a good idea. It talks about at end of life, whether you want heroic measures used to keep you alive. But we get this idea that you need a living will because when you go to the hospital, they ask you if you have a living will. Because there was a federal law passed that said if a hospital gets federal funding, when someone checks in, they have to ask them if it was a living will. The document you really need, to me, is a proxy directive for healthcare, because this is a document that's much broader. It has nothing to do with end of life. You may get better. You may improve. But meanwhile, you're in an operation and someone has to make a decision, or you come in and unconscious. This is the person who can make all of those medical decisions, decide on your care, the facility, the doctor, and most importantly, have the HIPAA language so they can have access to your medical records. I have had clients whose loved one was in the hospital and they showed up at the hospital and they wanted to know what's going on. The hospital said, I'm sorry, do you have something written that you can have access? Because of the HIPAA laws, we just can't tell everyone's condition. So that is, I think, the key document. A living will is nice if you're at end of life and you can't express that you don't want heroic measures alive. But there are a lot more medical decisions between now and end of life, and that's the proxy directive for healthcare.
I think that's a really good point. And that brings me to, what are some of the advantages, Victoria, of discussing long-term planning in a primary care office setting? Because I feel so often, the environment is usually more dire when people want to have the long-term care planning when they could essentially be doing it in primary care.
That's a great point you make. We really are trying to prevent any of these emergency situations where they're doing the advanced care planning documents in the middle of a crisis. So we really value our hospital social workers, and they do an excellent job, but the main goal is for them not to be given extra work or be juggling all of these different balls in the air, and helping the families or support systems who are there with this patient make these healthcare documents in the spur of the moment. So it's so important to really get this information prior to any urgent or emergent situations going on. And a lot of the reason why we find it so important really ties back to what I was mentioning before as well. When you go to the hospital, hopefully, knock on wood, there's not a lot of frequent hospital flyers in our chat today, but the idea is that you would not have the same level of correspondence interaction as you would with a hospitalist physician as you do with your primary care doctor. Hopefully the primary care doctor is someone you're following up with at least once a year. They're checking in on you. They know all of your healthcare and medical needs, but also they do know, again, if it's a good primary care doctor, and even if there's not a social worker in the office doing some of that background and getting the psychosocial history, a good primary care doctor gets that history and knows their patients well and knows them not just for their diagnoses anyway. So with that being said, the healthcare provider or the primary care doctor is an excellent place to start because they know you. They should know you. And they can really look at it from the approach of knowing the best way to advise you, given some of those healthcare situations that could be going on or some of those diagnoses, but also having a good understanding of what your needs are and what your goals of care are. So that's a big phrase that we use in our office quite a bit. If you are an active person and you want your quality of life to be this throughout your life, then when we're reviewing that living will portion, is it best for you to be DNR or not? And looking at those outcomes if a person were to be resuscitated, and it could really impact their quality of life following that. So really the main goal is to approach it and get a good understanding of, the primary care doctor knows you a lot better, or that is the goal. So having these conversations with people that you know, and bringing people into the office who may be helpful in understanding. So if it is a family member, very close friends, who are your chosen family members? Who is your support system? To have them come into the office. Here we actually do visits, and again, as part of my bio, Bianca mentioned, we do target the older adult population here in this office. So that's 65 and older, but we have had appointments before where the main goal for the appointment is to complete the advanced directive document, go through, identify the healthcare proxy, have those family members come in, and that's the main goal for the visit. And we're seeing that a lot more from a general standpoint with our Medicare annual wellness visits in addition, but we're also, if that is then coming up with the Medicare annual wellness visits, that's part of the questions that they ask, but that can ignite the spark. And then we're also able to have them come in for a visit if they want to just meet with me as the social worker, have another part of the visit with the doctor involved as well. But we are just ensuring that any questions you have, we're able to answer that with you, and we're bringing the appropriate people into those conversations as well.
Thank you. Do we have any questions from the audience that are watching? I know you all have been really patient and have probably learned a lot of things that have taken place during today's panel discussion. But if you want, you can post any questions now. You can either do it in the chat itself, or you can do it in the Q&A, and we can answer the questions live while we're here. And then here's a question that's come up. Is a proxy directive for healthcare the same as medical power of attorney? Have you seen what a DNI is?
All right. So yes, the answer to that is yes. They're the same thing. They're just different titles for the same document. A DNI is more like a living will. You can include some of that language in a proxy directive or a medical power of attorney, but a medical power of attorney or proxy directive meant to cover a much broader scope of things than just you're on your deathbed. I may also mention, because I put them in my proxy directives, families would love to know what you want done with your bodily remains. And if you want to have a funeral, or what type of funeral, or do you want, someone dies suddenly and everyone's going, well, what would they want? What would they want? It's really helpful if you have some idea what you want to put it in these documents.
And I think it's also important when looking at the two different sides. When we think of advanced directive, we really boil it down in our office with the living will or the directive portion versus the proxy or the medical power of attorney. So I always say this piece over here with the directive is what do you want? And this piece over here is who is going to advocate for you and help make sure that your needs are being carried out.
Good.
Thank you. I think so often because people already have a lot of anxiety when it comes to this topic, that when they see a lot of forms and documentations, they might feel even more anxious because now they're trying to read through all of these things and, learn the difference between all of these different options, simply because, it's not like this is a common topic for a lot of communities and cultures to keep in mind. I think, how do we encourage our loved ones to have this conversation? Because so often, I'll use myself as an example, I'm the oldest kid in my family. So when it comes to my parents, and as they're getting older and their health conditions, might start going a certain way, how would I encourage them to have this conversation and to plan with me?
I think it's all in the approach. If you say, this is something that you have to do, or you're getting older and you start almost blaming the person for aging or blaming the person for having these healthcare conditions, it's the approach and the language that we use that makes it a lot better. But if you turn it into a conversation and say, this is something I want to talk about, or this is something I feel that we should do together, then I feel that's a much better springboard, and it really opens the gates for open communication instead of almost posing it as like an accusation or you have to do this because you're older, and it's taking so much of the like blame or any sort of stigma language away from aging or away from, you know, having these different healthcare conditions. So we're turning it more so into, this is a conversation. This is, you know, part of everyday life. It's almost make a day out of it too. Like we actually got together with my family personally when my Nana started declining, and we had lunch and just talked about it over like a little lunch. We sat down, we had some tea, and it's okay, you want this, I want that, let's have this conversation. And it wasn't framed in a way that we said, okay, well, Nana's declining, so let's sit down and talk about what we want to do about Nana right now. It was, let's all have lunch and talk about what we want and how we can best care for each other, because I think that's the way that it needs to be framed, and that's a more positive and more beneficial way as we all move forward and try and advocate for each other and our loved ones and help each other, is to know that we're doing these things and having these conversations together.
I think also everyone knows of a bad situation either in their own family or something they've heard about from someone else. So just having conversations, as you said, Victoria, and making it part of an everyday talk that you would have. You're not saying to the person, we're having this conversation because you're dying. We're saying to the person, we're having this conversation in case something happens. I want to do what's best for you, and I want to do what you want, not what everyone in the hospital or everyone else has decided for you. And I think that is a good way to approach it. And as I said before, just using these real life examples that are all around us now in the news and as an icebreaker, and also the added dimension now that people can't have visitors come with them to the hospital, that they a lot of times are going to be by themselves. And if they're unable to speak for themselves, they want to know that the people in the hospital are calling someone who they've spoken to and knows their wishes and what matters to them.
I thank you. And I see here in the comment section, it says, can you comment on if there is a challenge from a biological family member versus the appointed proxy on decisions? What will happen legally? That's a great question.
If you have a proper document and name someone, they are going to have the right to do it no matter what your biological family says. Your biological family might want to bring it to court or something, but if you have a legal document signed, we do them notarized in our office, that's going to control. And particularly, you could put in the document, I don't want my biological family to make any decisions.
Wow, so you can get as specific as you really want it to be.
Yeah, we customize it for everyone.
That's good to know. Another question here says, what should a healthcare provider do if the healthcare power of attorney of an unconscious patient is directing care that is obviously different from what is in the advanced directive?
So the question is, if a healthcare provider
has
to do something that's different than in the directive?
It says, what should a healthcare provider do if the healthcare power of attorney of an unconscious patient is directing care that is obviously different from what is in the advanced directive?
Well, I always oppose giving a lot of instructions in these documents. You know, I want dialysis, I don't want that. Who knows what you're going to want? I mean, you want to give the agent a general power to make decisions. You could, you know, say, if I'm brain dead, I don't want to be kept alive, or if I have an incurable illness. But other than that, I think you got to limit the instructions and talk to the agent, and the agent's going to make the decision.
Thank you. I have another question, and maybe this can go out to Ray. You know, when it comes to in the LGBTQ community, how do we promote this conversation amongst our older adults? How do we promote this conversation with people that are not biologically related to us, but we know that they need to start thinking about this?
I think the first thing that we need to also consider in talking about all of these issues, and these are things that Victoria and Nina and Bill and Bianca, and yourself, Bianca, have brought up is to have this conversation in a way that allows for what we call, in my world, it has to be psychologically safe, a psychologically safe environment for the person to be able to have this conversation, whether it be for the patient or for the family members, okay? And, you know, what constitutes a psychologically safe environment? So let's talk about that. So for the patient, it has to be where, you know, the patient has to understand that, you know, given the gravity, the significance of the situation, that we're talking about his or her life, and that means also honoring who he or she really is, okay? So, and that involves, and that includes their own identity, being able to honor that and respect that and take that into consideration. As far as family members are concerned, I think we also have to be very mindful of should this person or should the patient pass, who are the cast of characters that are going to be left? Okay, and how do we address their issues as well? For some of the older LGBT adults, our brothers and sisters, they who are fortunate to have a partner, okay? Family members, other family members need to be able to honor and respect that and be able to address the issues that the surviving partner or spouse may have. And I think that's one of the things that sometimes we forget is what happens to that surviving spouse or what happens to that surviving partner. How do we address the things that they have to go through so that they themselves are able to survive and to cope and to thrive and to be able to live their lives. So, you know, I don't think there's a right or wrong answer or an exact answer to this, but I think more importantly, what we need to do is make sure that as we have these conversations, that we do it within the context of honoring that person's personhood. Because once you do that, the person then that we're focusing on has this idea of, okay, you know, now I can talk about this. Now we can talk about this because everything's on the table.
Thank you, Ray. And I think our final question is going to be, do you have to have a lawyer complete your advance directive, or could you do it without an attorney because costs might be prohibitive to some people?
I charge $175 to do a proxy directive for healthcare. That might be cost prohibitive for some people. I also do them on a payment plan when people pay me over many months. But if you really are strapped and can't even afford $175 for that document, there are places like the Chosen Family Law Center that will do proxy directives, living wills for people who are financially needy. And you can reach out to them.
We also, with Atlantic Health System, that's a great and wonderful resource, by the way, so thank you, Bill. But with Atlantic Health System, we have an advance directive document. It's rather simple, boiled down, but it was created by our legal team under the advisement of some physicians as well. So there are free versions out there. I do just caution where you are getting that document from. I would advise not just getting it from any old website on the internet, but you may be able to find a document with your healthcare provider or in the hospital or with Atlantic Health System. I do know that we have a free copy of the document. And with this particular document, you would not need to go to a lawyer or get it notarized, but you would just need 2 people to witness the document that were not designated as the healthcare proxy. So it provides another option for people if they don't have the funds to go to the to a lawyer or a notary and get it formally done. But again, I just advise to do a little bit of research into if you are looking for a free version of this document, where are you getting it from?
That's a really great point. Definitely being cautious. you know, we all know the internet can be very creative in many ways. Doing your homework is going to be key here. All right, so I want to look at the time and recognize that it is 3 o'clock, and as much as I would love to continue this conversation, I know that our panelists, you know, might have something else after this. If you still have questions, or if your question didn't get answered, or if you want to follow up with any of our panelists, I have all of their information and all of their emails, and I will be more than happy to send it all to you. I will also, I put a lot of links inside of the chat, so if you're not tech savvy and didn't catch all the links, please don't worry about copying and pasting all of it. I'm actually going to send you a nice email that has everything that was mentioned here, including the Chosen Family Law Center that Bill just gave us, the toolkit from Your Decisions Matter, as well as the Geriatric Assessment Center in Atlantic Health System, because we want you all to have access to this, and we want you all to be able to email us if you're having issues, if you are trying to figure this information out or trying to have that conversation. And so I want to thank you all for joining us for this program. This is also going to be recorded, or it is recorded, and I'm going to post it on our social media. I'll send it to you, Nina. I'll send it to you, Victoria, and Bill and Ray, if you want to post it on your own or in your agency, just so we can make sure that as many people as possible are seeing this and able to replay this back in case they need this information. So thank you all. I hope you have a great day. And I'll hopefully see you all soon when we can all get back together.
Thank you, Bianca.
Bianca.
Thank you so
Bye.
much.